Hi, this is Rick Wiggins from the University of Utah, and today we're looking at head and neck cancer lymphadenopathy. So we're going to talk about what are cancer nodes, and where are the nodes, and why you should care. So we'll start off with what are cancer lymph nodes, and it turns out it's not easy to tell normal from abnormal lymph nodes. Now, while it's easy on pathology to tell a clearly normal lymph node from an abnormal one, it turns out it's not as easy to do on imaging. Even with our cross-sectional imaging, it's sometimes hard enough just to figure out what is a lymph node compared to what is a blood vessel or what is a muscle. There's a lot of small parts, much less figure out what is a normal lymph node compared to what is an abnormal lymph node. It turns out it's just not that easy. Now, there have been several publications that describe maximal length or minimal diameter of lymph nodes. It turns out that the length and the size is not always that important, especially when they're small. So what is important with these lymph nodes? Well, the configuration is important. We like it to be a nice kidney bean shape and have a nice fatty hyla like this lymph node here. We like it to be homogeneous. We like it to enhance to the same degree throughout itself, as well as the similar lymph nodes in the cervical soft tissues. And we look for its borders, things like loss of the surrounding fat planes, which is characteristic of extracapsular spread, which is very important for cervical lymphadenopathy. Now, when we have a case of a clearly abnormal lymph node, it's not that difficult to tell. Here's a necrotic node, very heterogeneous density, and we see this fuzziness around the outside that's consistent with extracapsular spread and loss of the fat plane here between the submandibular gland and back here between the SCM. That one's pretty obvious. It's when they're smaller that the radiologist's role is very important. Here's a case of a patient who had a lateral tongue ulcerative crater squamous cell carcinoma on this post-contrasted CT image, and we can see on the same side, there was a necrotic lymph node that was initially missed on imaging. And this is where it's important for us to think about those imaging characteristics of those lymph nodes. Now here's a case where we had bilateral lymph nodes under the mandible that initially looked normal, nice kidney bean shapes and nice fatty hyla. As we follow the node on the left, however, this is clearly an abnormal lymph node. We have a necrotic focus within the pole of the lymph node. This is a 3D reconstruction I made of that same lymph node. Again, this node is kidney bean shape. This node has a nice fatty hyla. This nice node is relatively homogeneous otherwise, with enhancements similar to other lymph nodes in the neck, but it's clearly an abnormal focus within the nodes, even though it meets the size criteria on imaging. So we want to remember those imaging characteristics of abnormal nodes. Now here's an example of a coronal fused PET CT and the correlating PET image on the other side, on the right. And we see all these lymph nodes. This patient had 15 lymph nodes throughout their cervical soft tissues that were all positive, but all under a centimeter in size. So it turns out if you just look at the pathologic specimens from neck dissections, frequently, sometimes about half the time, those lymph nodes that are all full of tumor may be under a centimeter in size. So it's much more important for us to look at the imaging characteristics of these lymph nodes. So that's what are cancer nodes. Next we'll talk about where are the nodes. Now we can think about these lymph nodes in terms of anatomic groups or surgical levels with the Ajcc criteria. And it's important for us to be using the same words that our surgeons are using before they get here to the operating room. So whichever way we describe these nodes is fine, as long as we're using the same words the surgeons are using. So first we'll talk about anatomic locations. There are a lot of lymph nodes that are just spread out along the face, and they're very important in terms of tumors of certain areas, but they're not included in the Ajcc criteria. These nodes we can just name on their location. Here's a node in front of the maxillary sinus, so that's a good example of a facial lymph node. Here's a lymph node that's behind the external auditory canal, so that's a posterior auricular node. Here we see on this axial post-contrasted and the correlating coronal post-contrasted several lymph nodes within the parotid. The parotid is the first nodal order drainage station of the pinna of the ear and the periauricular skin. So it's very important for pathologies in that area, but it is not included in the Ajcc criteria. Here's a node back in the occipital soft tissue, so that's an occipital lymph node. Several nodes that are just spread out along the face, and we sometimes use anatomic locations to describe them. But we also have these chains of nodes within the cervical soft tissues. Anteriorly along the internal jugular vein, there's this chain of nodes. So that is the internal jugular chain nodes. Posteriorly, we have the spinal accessory chain nodes. And inferiorly, connecting those, is the transverse cervical chain of nodes. So together, those lymph node chains make a triangle in the cervical soft tissues, and those are important in terms of lymphatic drainage of pathologies, specifically cancer. There are some lymph nodes that are given special names based on their location. One of those is the sentinel or jugular-digastric lymph node. That's the node at the top of the triangle. These are often the largest in upper respiratory infections. But we see they still have a nice kidney bean shape. Next, we have retropharyngeal nodes. So between the airway and the vertebral body, we have the retropharyngeal space where we have fat as well as lymph nodes, and we see these very large retropharyngeal nodes at that side. Next, we have the signal or Vercau node. This is a low left supraclavicular fossa node that may signal a primary in the chest or abdomen with pathology spreading along the thoracic duct and may present with a lymph node in the left supraclavicular fossa. And we have prelaryngeal. This is a prelaryngeal or Delphian lymph node that's in front of the strap musculature. So those are all anatomic descriptions of nodes. The other system is the Ajcc system when we're talking about the TNM staging. The primary tumor, N is for the lymph nodes, and M is for metastatic disease. So we have all these levels throughout the cervical soft tissues that are described in the Ajcc criteria. So first we have level 1. This is below the mandible and above the hyoid here in this graphic. And here's an axial T1 post-contrasted. Between the anterior bellies of the digastric, those are level 1A nodes, or submental nodes. Out lateral to the anterior bellies of the digastric, in front of the submandibular gland, those are level 1B nodes. Next is level 2. These are the high internal jugular chain nodes above the level of the hyoid. Now this is an example of a patient who had large solid lymph nodes throughout their cervical soft tissues, and it helps us to remember these different nodal groups. If we find the submandibular gland and draw a line in the coronal plane through its posterior edge, that helps separate for us the level 1B nodes anterior to that line from the level 2A nodes posterior to that line. Now if we find the internal jugular vein, and then we draw a line in the coronal plane through its posterior edge, that helps separate for us the 2A nodes in front of the jug from the 2B nodes, which are more than a fat plane behind the internal jugular vein. So here's an example of an axial post-contrasted CT. This patient has a palatine or faucial tonsil primary squamous cell carcinoma and a level 2 heterogeneous necrotic node on that side. So next we have the level 3 nodal group. So this is the mid internal jugular chain, and that's going to be between the hyoid and the bottom of the cricoid, as we see highlighted in this graphic. So here's an axial post-contrasted CT, and we see these level 3 nodes. We're below the hyoid but above the cricoid, and we see these nodes posterior to the internal jugular vein. Next we have level 4, so this is the low internal jugular chain below the cricoid. And here's an axial post-contrasted CT. We're at the level of the thyroid gland. Here's a common carotid. Here's the jug. Here's a sternocleidomastoid. And we see these level 4 nodes out laterally within the cervical soft tissues. Next we have level 5. This is the posterior cervical triangle node, posterior to the sternocleidomastoid muscle. And sometimes they're separated in a 5A and a 5B by the bottom of the cricoid. That also separates level 3 and 4. So here's that same axial post-contrasted CT with solid nodes throughout the cervical soft tissues. Now if I find the sternocleidomastoid muscle and I draw a line through its posterior edge, that's going to separate for me the level 5 nodes, which are centered posterior to that line, posterior to the sternocleidomastoid muscle. So here's a post-contrasted axial CT, and we see this lymph node behind the sternocleidomastoid, so that's a good example of a level 5 lymph node. And here's an axial T1 MRI image. And again, we see some supraclavicular nodes here, again, centered posterior to the SCM. So that posterior line of the SCM is going to separate level 2, 3, and 4 along the internal jugular chain from level 5 posterior to the sternocleidomastoid. Next, we have level 6. This is anterior midline. We can think about these lymph nodes as all the nodes that are between the common carotid arteries below the hyoid. And this is going to include the prelaryngeal, the pretracheal, and the paratracheal nodes. So here's an example of a level 6 lymph node in front of the strap musculature below the hyoid. And here are some other level 6 nodes. So here's the trachea, here's the esophagus. We're at the level of the thyroid, and in the TE groove, we have these level 6 nodes. So if we think about the level 6 as roughly the nodes between the common carotid arteries here and here, that's going to remind us that it includes the TE groove nodes. Now next we have level 7. This is the superior mediastinal nodes down here low on this graphic. And here's an axial post-contrasted CT, and we have these lymph nodes here within the fat behind the manubrium. So when we get down to the level of the clavicular heads in the manubrium, we can see small lymph nodes there anterior to the airway. Those are level 7 lymph nodes. So those are the locations of all these lymph nodes, and we can think about them as either anatomic groups or surgical levels. Whichever system you're using, just be sure your surgeons are using the same words. So now just to wrap up, hopefully convince you why you should care about these lymph nodes. Why are these important? Well, it turns out if we think about the single most important prognostic factor for squamous cell carcinoma of the head and neck, it's actually the presence and number of pathologic nodes. It's not the primary, where the primary is, or where it goes. It's the presence and number of pathologic lymph nodes. That's what's most important. Now, we know that most patients with head and neck cancer already have metastatic disease at the time of diagnosis, or at least almost half of those cases. About 43% may have regional nodal involvement, and about 10% may already have distant mets. So these nodes may already be present in almost half the time. We know that the presence of nodal metastatic disease also decreases survival by 50%. So if we see a definite pathologic node, we just cut that patient's prognosis in half. And the presence of nodal metastatic disease doubles the incidence of distant mets. Well, what about extracapsular spread? Is that important? It turns out yes. If we see extracapsular spread, that also cuts the patient's prognosis by half. We know that it increases the risk of recurrence by 10%, and it increases the risk of distant mets by 3 times. So how about drainage routes of lymph nodes? Are those important? Well, they are. For one, it draws attention to regions of likely spread of primaries. If we have a primary or certain location, we can think about what lymph area. So here's a patient with a pathologic cancer here on the base of tongue, and we think about base of tongue and the palatine tonsil often draining to level 2, so we're going to look at the level 2 nodes very closely. Well, the opposite is also true. If we see a definite pathologic node, we can think about what primary sites drain to that area and look at those areas closely. So here's an example of a patient with a definitely pathologic level 2 lymph node. We know that the base of tongue and the palatine tonsil drain to that area, so we look at those regions and we see the palatine tonsil primary in this case. Well, it also helps us because borderline suspicious nodes in other locations may be less suspicious to us. If we have a patient with a very low hypopharyngeal primary and we're slightly suspicious of a level 2 node, that lymphatic drainage doesn't make as much sense for squamous cell carcinoma, so we may be less suspicious of this lymph node. Also, if we find a definite pathologic node in a different region, that can suggest to us a second primary. So here's an example of a case with a palatine primary squamous cell carcinoma and an ipsilateral level 2 node. If that patient also had a very low left supraclavicular node on the contralateral side, that may suggest to us a second primary because that lymphatic drainage doesn't quite make sense. We also know that we have a worse prognosis with the greater number of nodes involved, the more nodal chains that are involved. When those pathologic nodes are bilaterally, And the lower pathologic nodes that we see in the neck, the worse the prognosis. Now, with the Ajcc criteria, we think about the nodes. They're very important in the T and M staging. And in the 2010 revision, they did add a modifier for extracapsular spread, either being positive or negative. So that is a run-through of lymph nodes. What are the lymph nodes? Where are the nodes? And hopefully now you understand why you should care and why they're important to mention in our reports. And I thank you very much for your attention.